I'd like to introduce our next speaker, which is Associate Professor Leanne Hides, who is she holds an Australian Research Council Future Fellowship at the Queensland University of Technology and is a clinical psychologist with expertise in the treatment of youth substance use and comorbidity. She's the Deputy Director of the Centre for Youth Substance Abuse Research and leads the QUT eTools for Wellbeing project, which is part of the Young and Wellbeing Cooperative Research Centre. Leanne's going to be talking in regards to improving treatment of youth substance use and comorbidity. So welcome, Leanne. I'll open.
Okay, so as Linda just mentioned, I'm going to be talking about youth comorbidity and how we treat it. And I'm going to talk a little bit about the challenges that we face with youth comorbidity, what the current evidence is in terms of treatment, and then some new innovations we've got in terms of face-to-face interventions as well as e-health. So I won't go into the stats too much because I'm sure you've heard them all before, but we know that 1 in 4 young people will have a mental health disorder, and obviously substance use is the second most common, anxiety the first, and depression the third, but we also know that they very commonly co-occur. And we know that only 1 in 3 people with mental health disorders seek help, and that's less than a quarter of young people with mental health disorders seek help. So there's a lot of disability around mental health in young people, but very little help seeking. And we know that's particularly the case when it comes to substance use disorders. And as you can see there, only 7% of males and 80% of females with a substance use disorder will seek help. So we've got a massive challenge facing us. And I guess when I was writing this talk, I always say comorbidity is the norm, not the exception. And I guess lately I've been feeling a little inspired by Pat Corrigan's work about coming out of the closet in terms of mental health. And I guess it got me thinking, what can we actually do to try and increase help seeking in young people and decrease stigma about that? And it got me thinking that we really probably need to have a good look at ourselves and our own attitudes towards mental health and comorbidity in particular. So this is a picture of my mother and her sisters. I love this picture. I love how they've all got the same hairstyle. And they all look fabulous. So this is just my family history. So this is one of my aunts. She has quite severe anxiety and frequent panic attacks. My mother has had several depressive episodes in her life. She nearly missed my wedding because she was an inpatient for depression. She's had numerous bouts of ECT. This is my auntie, Maureen, who recently died from untreated cancer because she had agoraphobia and didn't get to a doctor. And this is my auntie Lee, who's had bipolar disorder her entire life. So all 4 of them have suffered from quite severe mental illnesses. And I guess when I was growing up, I was not really aware of that. We heard about people having mental breakdowns and, it was never really discussed, was it? And if you think about your own family upbringing and think about the language that was used around mental illness and how things have hopefully changed a bit these days, but not so much. And I wouldn't suggest people doing this on a first date to a room full of strangers. But this is my family tree of mental illness. And I kind of thought about it for a long time, and I thought, do I need to come out of the closet a little bit about this? So I've colour-coded it to keep it simple. So blue is depression, green is anxiety, and that orangey colour is substance use. So my grandmother on my dad's side had depression. My grandmother on my mum's side had depression. She was in and out of Wolston Park Hospital most of her life. She was unwell for about 35 years. My mother, as I've already mentioned. My older brother, had depression. I've had depression, and I'm treated and I'm a survivor. My dad's got anxiety. My mum's got anxiety. My brother had quite severe social anxiety, and then he became depressed as an adolescent, ended up in an inpatient hospital. I've also got substance use. My father's you know what I'm saying, my grandfather, he was in the railway, so he was a guard in the railway, and those guys were drunk all the time. They were the guard in the back of the train, and they were just drinking the whole time because it was so boring. My grandmother also had a drinking problem. So did my grandfather. They met in a bar. My grandfather used to run a butcher shop in the valley here, and he'd drive home every Saturday night over the Story Bridge. Must have been terrifying for people. And my older brother has also had substance use issues. So you can see there that every member of my immediate family has mental health issues. But there's also a lot of comorbidity. My grandmother, my mother has both depression and anxiety. My brother has depression and substance use. And my younger brother has depression and anxiety. So you can see how comorbidity is the norm, not the exception in my family. And I think we need to think about our own experiences with mental illness, and as well as our family, and we need to learn from that about our attitudes towards it, and sort of start reframing it as a survivor, like a more positive approach to mental illness in terms of, I've survived depression and I'm doing really well. And, you know, it knocked me over for a while, but I got up again and everything's okay. And we need to think about how we give young people that message. Because at the moment, we're all in the closet, we're all keeping it quiet, we're not talking about it. We need to tell a story of us being survivors. And I guess the other thing we need to think about is the climate in which young people are growing up. I love this picture of the glass of alcohol for Australia, because that really encapsulates Australia's attitudes towards beer in particular, but substance use in general. We know young people are drinking at risky levels weekly, at least 70% of them. And this is the FAIR survey. I love their question about drinking to get drunk. So we all go, Gen Y, they're such a disgrace. Look at them. 60% of them are drinking to get drunk every time they drink. But look, the rest of us are, 34% of the rest of us are as well. So there's a real drinking culture in Australia, and that, we do drink to relax and wine. And a lot of people drink in perfectly acceptable ways, but I think it's about the messages we're giving young people. So in terms of the challenge, I think we need to think about drinking and getting drunk is quite common in young people. It's quite normative for them to do so. And the suggestion that they shouldn't do that is quite foreign to them. Drinking and other drug use rarely occurs in isolation without other mental health issues going on. So if you've got to go to a party, you have a few drinks beforehand so you don't feel nervous when you get there. If you want to pick up chicks, you go and have a few drinks so you can go and talk to girls. And I guess what I'm saying is, to address these issues and increase help seeking, we really need to think about stigma, our own attitudes towards that, and how we can start having more open conversations about this. Why is it so difficult for me to tell you that I've got a history of mental illness, given my family history? But it is incredibly difficult. So we need to start talking about it more. And I think we also need to think about Australia's mental health literacy in terms of giving people the language to communicate this to each other in a non-stigmatising way. And also, once again, Australia's drinking culture. So we think about current treatments for youth comorbidity. We have to go to the adult literature because there's not much literature in the youth and the adolescence area. And I was involved with a series of systematic reviews that Amanda Baker from the University of Newcastle performed a few years back. And the basic story is this. If we look at comorbid depression, anxiety and substance use in adults, if we're looking at alcohol outcomes, both motivation interviewing, brief format, and combined motivation interviewing and CBT reduces alcohol use, and it also results in reductions of depression and anxiety. But CBT has slightly better outcomes. I think, that's fair enough, because you get a bit more treatment, you'd expect some better outcomes. So alcohol, it's okay, but when we look at cannabis use, MI, CBT tends to do better and have better outcomes in that group. When we look at comorbid psychosis, another review that Amanda did, they found that brief intervention was actually better than CBT for reducing alcohol in this group, and that MI, CBT had better depression and cannabis use outcomes. So it's a bit of a mixed picture depending on what kind of drug is their drug of choice, what kind of outcomes you're looking for. But the good news is that across the board, brief motivation interventions tend to work. They tend to help these individuals with quite severe and complex comorbidities. And as Marie said, we can take this stuff online, which is some of the work that Frances K. Lampkin has been leading. So let's go to CBT for depression, alcohol dependence in adolescents. Very few studies, as Marie mentioned. We know that CBT is effective when we combine it with SSRIs in adolescents with comorbid depression and alcohol dependence. I did a study a few years back now at Origin looking at 10 sessions of integrated motivation interviewing CBT with young people. And we had pretty good outcomes. So we found that 84% had a partial or full remission from major depressive disorder at 6 months. We got reductions in depression, anxiety symptoms, some good substance use changes, but this was uncontrolled. This was just a trial that we did within a clinical setting. So more work needs to be done to see whether CBT is more effective than other interventions in this age group. There's been quite a bit of work done, as you all know, for motivational interviewing with adolescents, and these are some systematic reviews here. And so we know it basically has small to medium effects over short term, and sometimes they maintain change, sometimes they don't. So overall, pretty effective. And as you can see from that Barnett review of 41 trials in adolescents, we found about 63% of them achieve a reduction in alcohol, tobacco, cannabis and other drug use. So in summary, the current evidence around the treatment of comorbidity in young people is that motivation interviewing, while brief, is quite effective, but it only has small effects. And it's unclear if CBT is required for comorbidity in young people, but I think it's probably pretty likely, given the complexity that Fraser was just talking about that we face. The issue, though, is are young people with comorbid conditions going to engage in CBT? Are they going to come to 10 to 20 sessions of therapy? And from my experience in clinical trials, it's bloody hard to get them there for that many sessions. So I think that's the other thing we need to think about is yes, it might be more effective, but is it better to do something briefer to get them in and to get some good outcomes? So this leads into some of the work that I've been doing recently around how can we, I guess, thinking about young people, how can we improve motivation interviewing interventions enough so that they're getting a little bit more of an effect, so we're trying to increase the effect size there and the outcomes, without it becoming too laborious for them. And also, how can we use technology to increase access for them? So this is a randomised controlled trial that I did at Western Melbourne Headspace when I was at Origin. And what we did there is we recruited young people who were coming to Headspace who had alcohol or cannabis use, as well as a Kessler's 10 psychological distress score of more than 17, which is indicative of the presence of anxiety or depression. And what we found was that we got some pretty good outcomes. So for alcohol use, we got a significant reduction in the number of standard drinks per drinking day they were having. At 1 month, that was then maintained, and then it was significantly better than those in the control group at 1 and 3 months, but not 6 months. They also got significant reductions on the Kessler 10, so their psychological distress went down compared to controls. So in that intervention, what we were doing there was we were looking at adding coping skills to motivation interviewing. So what we did is when they came in, we sort of said, tell us what's going on with your substance use, tell us what's going on with your depression or anxiety or whatever they were coming in with. We were trying to work with them to figure out what the relationship was between the two. And then we were just trying to give them some coping skills to try and manage their mental health that didn't involve substance use, or vice versa, depending on whatever they wanted to target. So we had a range of coping skills that people could utilise. So we had different types of cognitive coping skills. So we had some mindfulness stuff in there about attending and letting go of your thoughts. We had some behavioural interventions about increasing activity levels and feeling good. And we also had some more effective ones about some deep breathing and calming yourself down when you're in anxious situations. So that was a 1 to 3 session intervention that we did with them. And so we found that coping skills training did enhance the effects of motivation interviewing. But I guess we didn't really know about whether that was enhancing the effects beyond traditional motivational interviewing that doesn't have coping skills training. So that's what we wanted to find out. And while we got good effects, we thought, well, can we try and improve this more by actually targeting interventions to young people around that substance use risk profile that they had and that relationship with mental health? So this is our current study that we're in the final stages of recruitment for. And what we're doing here is we're trying to compare sort of an assessment feedback control condition with a traditional motivation interviewing intervention, no coping skills training whatsoever, with motivation interviewing with personality targeted coping skills training. And what that means is that when they do their assessment, they complete a measure called the substance use risk profile scale. And that tells you whether there's a relationship between their substance use and their anxiety or depression, it tells you about the relationship they have with alcohol. So the first group what we call anxiety sensitive. So these are the people that feel really nervous and then drink to try and calm themselves down, particularly in social situations. Negative thinking are your depressive personality style, so they're the more drink alone to pass time kind of thing. Impulsive group are the kids that just get into everything. It's just go, go, go. Drugs, alcohol, you name it, whatever's on the go, they're into. And then sensation seeking, which are the ones that are looking for the next high, the next thing to feel really good about, but then unfortunately just jumping to the next thing a bit too quickly. And we know that in terms of the relationship between these variables and substance use, the sensation seekers tend to be binge drinkers. The impulsive ones tend to drink but also take more drugs. Anxiety sensitivity has also been associated with early onset and binge drinking, and to a lesser extent, negative thinking. So once we've got this personality risk profile, and we work with the young person to sort of identify if what we're coming up with sounds right to them, so we give them feedback on that. And then what we're doing is we're trying to just try and give them some coping skills training to try and reduce that level of personality risk that they might have. And so we offer them between 3 and 4 different types of coping skills, and they choose which one they think might be useful for them, and then we train them in it on top of traditional MI. The other thing that we do is we work very hard with them to think about their alcohol goals. And this brings up the concept of what we call the stupid line. So that's the point where drinking stops being fun and starts getting messy. And if you talk to young people about it, they've all got a few stories about this, as I'm sure you all do as well. I think we've all woken up on a Sunday and said, never drinking again, blah, 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 and then drank again not soon after. So young people do that quite often, it's no surprise. And so we get them to think about, rather than just binge drinking and just drinking to get drunk every time they drink, think about the type of night out they want to have beforehand and how many drinks might go with that. So for example, if they just want to relax and chill out and watch the footy, you know, maybe you don't need to drink a carton of beer, maybe you can just drink a 6-pack, that kind of thing. As opposed to a crazy night out where they'll just do everything. So we just try and get them to think about their patterns and what their plans are for the night, and try and get them to set some goals and try and monitor how they go with that goal. So that's a current trial that's still ongoing, that's been funded by the NHMRC, and we've been working with Chaplain Watch and recruiting young people through Fortitude Valley on their foot patrols and the Night Safe Recovery Centre, as well as the Drug and Alcohol Brief Intervention team at Rural Brisbane. So we have a research assistant who accompanies them on Friday and Saturday nights and then goes to the Rural Brisbane Emergency Department and recruits intoxicated young people. If anyone wants a job, let me know. It's sort of hard to keep people in that role because their hours are 11 p.m. till 5 a.m. It's a bit of an ask. So now if we think about technology, so I guess what we're trying to do in the previous section is thinking about, well, how can we make brief interventions more effective by squeezing a bit of CBT into it but not overdoing it so it's not overwhelming for the young person. The technology aspect is more about how can we get information out to young people. Given they're not help seeking, how do we get the information to them? And we all know they're online. We know that 100% of them check the internet, they've all got smartphones. I think this statistic's interesting. 80% of people check their phone within 15 minutes of waking, and we have it with us for all but 2 hours of our waking day. Who's guilty of that? Hands? Yeah. It's quite disturbing when you think about it, isn't it? But I guess, so this is all about how we can use that to get information to young people. It obviously needs to be engaging and interesting. But I guess what we can do is, even if we are getting quite small effect sizes in terms of interventions, getting that out to young people on a mass scale can have a massive impact. So no matter how small the effect, from a public health perspective, if we can get that message out to young people, we can bring about quite a bit of change. And this is a review of web-based interventions targeting substance use that came out in 2014. So there's been 23 studies, which isn't bad for this, for a relatively new area. And what we see there is that we do get significant reductions from online alcohol interventions. So you can see there at 3 months we get a 3 standard drinking unit reduction, which reduces by half by about 12 months, and then the effects disappear by 12 months, unfortunately. So I guess what that's saying is we need to do a bit more boosters and kind of maintenance type interventions, which with the web-based intervention you can do easily with emails and SMSs and things. Another space that we've been working in is the app space. So I'm just going to briefly talk about an app that we've developed and tested recently as part of the Young and Well CRC. So it's called Ray's Night Out, and the idea of the app is that you take him out for a night out. He's probably going to drink, but we don't make that the premise for the app. And what the app's trying to do is promote harm minimisation and controlled drinking strategies in young people. So we're trying to increase safe drinking behaviours and their awareness of their alcohol use limits. So you can see there that you can pick what kind of night out you're going to have, whether it's going to be a fun night, a chilled night or a crazy night. You get to preset how many drinks you think that might be if you're going to drink. He gives you some feedback about that because he's only a panda, he can't really drink 20 drinks. And then you start playing the game. So you can see down on the left there's a bit of a menu. And what you can do is you can buy Ray food, buy him drinks, including non-alcoholic drinks, dancing, and that's his piggy bank. And the whole premise of the game is you can take Ray out, you can show him a good time, but you can't get him drunk or he doesn't have a good time, basically. So it's about learning to drink, to have a good night out without the negative consequences, which is what we're trying to aim at. So that's Ray having a soft drink, having some food. He flirts badly. And the other thing is the more drinks he gets, his behaviour changes, so he starts to sway. His flirting becomes ridiculously bad, like with a wink and stuff, which is really creepy. He dances, and the more drunk he is, the crazier he dances. We've also got some alcohol trivia in there, so this is how we're trying to address knowledge by making it like a pub trivia thing. So the participants ask questions and they answer true or false and they get some feedback. You can see up the top there that there's points, so we call them good vibe points. And once they get a certain number of points, they can unlock photobooth rewards. So the first one's like just a kiss hug one, so you can get your photo taken with him in the picture. And that can be shared on social media and things like that. And then, of course, if you insist on buying him drinks, you can see those bottles on the right, they change colour. So when they're red, he's approaching his stupid line and he gives you warnings. And I should add that the stupid line is random, so it does change. And then if you give him too much, of course, he throws out. And then if you keep him drinking, he will eventually pass out and then probably go home in an ambulance or something like that. So does it work? Kinda. We weren't really sure if it would work. So we've done a randomised controlled trial with 197 young people, and they were all just required to have used alcohol in the past month. And what we did is we gave one group immediate access, another group delayed access to the app. And then we followed them at 1, 2, 3 and 6 months. We were interested in looking at the impact on alcohol knowledge, alcohol use and related behaviours. Now, we didn't really think it would have much of an impact on alcohol use behaviour because it's so hard to change in this age group, but we thought, we'll look at it anyway and see what happens. So what we found was at 1 month, when we compared the delayed group with the immediate access group, that those who got Ray, actually their knowledge increased significantly more than those that didn't get the app straight away. So there's one good thing we found, so in terms of showing that the app has efficacy in terms of increasing alcohol knowledge. We found other good outcomes, but we didn't find any more other group differences at 1 month. And the problem was that by 2 months, everyone had had the app. Because it's incredibly difficult to do no treatment control studies in these young people because they all think they're missing out on something. So even that 1 month delay was hard for some of them. So we can see there that young people at 2, 3 and 6 months achieved reductions in the mean number of drinks that they drank when they went out and also the maximum number of drinks. We didn't have any change on frequency, but I guess what that's saying is that they reduced the quantity. So hopefully we're trying to stay below their stupid line. We also found significant reductions on alcohol-related problems. They stopped getting into trouble while drinking. Their audit scores went down. And we also found a significant reduction on psychological distress, which we were quite surprised by, but it's a good thing, so we'll take it. This is some of the feedback young people gave us about what they thought about the app. So 77% said it helped them identify drinking goals, 46% said it helped them identify their stupid line, and you can see that only about 40% said it influenced them to drink less, which I think is fair enough given it's an app and they weren't seeking help for drinking, they were just trying something for us. But I thought the good thing was that 80% said the app gave them some helpful hints for how to drink safer. In terms of app quality, it got 4 out of 5 stars, and it got high 4 out of 5 stars for its functionality, how it looked, and the quality of information in it, but 3 for engagement, which I was a bit surprised by, but that's okay. I'm a bit close to it. So in conclusion, I guess what I'm saying is the treatment of youth comorbidity is challenging. I think we need to do something about stigma, and I think we need to think about what we can do ourselves about stigma, what we can do about getting mental health literacy of young people, adults and their families up. We know that motivation interviewing interventions have positive outcomes, even though they're brief. They can have small effects, but I guess what I'm trying to show is that we can enhance their effects, and that technology has a critical role in increasing treatment access, which then will give us the potential to have huge population benefits, even if we're just doing something like giving them an app to play with that helps them identify their stupid line and maybe not drink so much when they go out drinking next time. And finally, just, I guess, so young people can stop feeling like that little person in the middle. If we can all try and embrace them and try and help them find the help they need and help them get the message that it is effective and it can be good and it can make things better so they can move on and live happy and healthy lives. And just thanking all of my collaborators who are listed there. Thank you.